Next. True? Again, it's a degenerative joint disease. Probably all of us have some osteoarthritis, right? Okay? It's somewhat a function of getting older, but it's also not a normal thing. We're trying to avoid the development of developing an osteoarthritis. But it does have, the prevalence does increase with age. Because what do we call it? The wear and tear disease. The more we use a joint, we break down the bone, right? That we're looking at. It is the most common type of rheumatic disease. If you're over the age of 65, you probably have some osteoarthritis. And what happens with that osteoarthritis? What's happening to the bone? Pardon? The cartilage, okay, that joint cartilage and associated changes. Is there a family predisposition with osteoarthritis? Yes, definitely a family predisposition. So you wonder what the role is there. What happens? You know, is it an immune response? You know, people are starting to think about that in what we're looking at. It is the wear and tear disease. There is destruction of the cartilage. And then what happens with that destruction of the cartilage, they get some new bone formation at the edges of the joint. And what that does is it just creates sometimes some more friction and pain for what they're dealing with. So where do you usually see this if it's a wear and tear disease? Knees, hips. Some people in their back, weight-bearing joints. So what are your weight-bearing joints? It's going to be your vertebrae, it's going to be your hips, and your knees, like you mentioned. Okay? And again, who's also at more risk of developing that osteoarthritis? Okay, postmenopause because of the osteoporosis. Smokers will play a role. How about weight? Weight is a huge role, okay? And people who do repeated stress with their joints, okay? Pardon? Okay. Construction workers, the guy who does the hammer all the time. Okay. People who run jackhammers. Violin players. They tend to get arthritis in their fingers. Yes?
My dad just got surgery in December for osteoarthritis in his vertebrae, but it was because of up and down movement of his arms from work.
The up and down movement, the constant movement. Yeah, that'll do it. So it's that repetitive movement that plays a role. And what happens with that constant repeated stress on a joint is you lose some of the elasticity in that joint. It just doesn't want to move as quickly. Okay, so you lose kind of that shock absorber function in that joint. And what they see on X-ray, when you start losing that shock absorber function and that cartilage, is the joint space starts to decrease when they take X-rays of that joint. And you start losing some of those changes. One thing that they're really starting to look at is we talk about this as being a wear and tear disease. So when we're talking about that, we're talking mostly about a mechanical issue, aren't we? Something mechanical. So yeah, mechanical, things like that. Constant running, repeated stress. It's a mechanical function. What they're starting to look at more now is to look at some of the biochemical things that are going on. Okay? What's the biochemical changes, especially in that subchondroid tissue? Because what they're, we mentioned there's a familial pattern, right? And with that, they're looking at these changes and what's happening, questioning possibly an autoimmune cause and genetics. Because if you have identical twins, 70% rate that they both have significant osteoarthritis. Okay? A 70% increase a chance that they will have osteoarthritis than if they were fraternal twins. So that's significant when you look at that. But what happens is that auricular plate just starts to disappear. You get those bony spurs. That joint cartilage just starts degenerating and atrophies. And you may actually see some sterile joint effusion. So if they take this, they're not going to really find a lot of WBCs. Okay? You don't have the inflammation. It's just wear and tear. Again, aging usually begins by the 3rd decade of life. Okay? Starts earlier than what you think. Okay? And by the age of 70, 80% have some form of bone degeneration. Obesity plays a role, especially in the hips and the knees. Overuse that we mentioned. Things that cause joint hyperextensibility, those gymnasts, they end up with arthritis in those joints. Osteoarthritis. Congenital abnormalities and some of your metabolic diseases increase the risk. Paget's disease, hemophilia. But the primary cause, again, looking at an autoimmune response and other overuse in the mechanical issues. What do people complain about? Pain. They hurt, right? They ache. It's the most common symptom. Usually, is it worse with activity or not? Worse with activity, gets them better with rest with OA. Okay? Worse with activity, intensifies with that activity. If it's rheumatoid, it's better with activity and gets worse with rest. Okay? And as it progresses, even slight motion can cause pain. A lot of times, if you're doing an exam, you move a joint, they're going to complain about pain with just the range of motion. Crepitus. What's crepitus? Okay, that's that grating sensation. Okay? It can be either felt or heard when you're moving that joint. I used to play golf with a person, and it just drove me crazy because every time she walked, it was like creak, creak. Okay? And unfortunately, as it progressed, we weren't playing 9 holes anymore. Okay? Just couldn't walk that much. A lot of stiffness when they get up and moving, some bony hypertrophy, muscle atrophy because it's not being able to, you're not using it. The muscles atrophy. You'll see effusions to the point that they may have a contracture. They don't have a bony ankylosis. They don't have a lot of that bony formation of the pannus building in there like you do with RA. But it just gets immobile and atrophy and stiff. Okay? So they start losing their functional ability. Some of the classic things they call with that bony hypertrophy is Heberdine's nodes. There was a Dr. Heberdine who described these, so he called them after himself. Okay? As opposed to RAs, these tend to be in the distal joints, these little nodes, those distal interphalangeal joints. They can be painful and red. Okay? Interesting, 10 times more common in women that get those Heberdine's modes. The other thing is Bouchard's nodes. Okay? And those are, again, in the proximal. These are, again, proximal joints of the fingers. And what happens is a lot of times these are because of repetitive movements. So those are the violin players, the piano players. Diagnosis, what? Signs and symptoms, right? X-ray will show some of those joint changes. They'll see the narrowing of that joint space, some bony hypertrophy. Serum labs are usually not that helpful. The SED rate might not even be up because it doesn't seem to have as much of an inflammatory response. So our goals of treatment are what? manage the pain and the inflammation, prevent that joint deformity, keep that function moving, and educate that patient. So what do we do for pain? Rest, right? We can rest the joint, and that's local and systemic. Sometimes with pain, we may immobilize the joint for a period of time or decrease weight bearing. It's quite interesting that they're finding a bigger correlation with weight with the osteoarthritis. They're finding that weight reduction can play a big role because adipose tissue produces leptin. Okay? And that's a cytokine. And that can really ramp up the inflammatory response. So if we can get weight reduction, hopefully it should decrease that osteoarthritis response and what we're looking at. What about positioning? Functional. Okay, we want to keep things in a functional position. Okay, which sometimes can be uncomfortable for a person to brace or keep it in that position. But you need to do it periodically. And always, if you're bracing or doing anything like that, you are checking the skin and the circulation. Okay? Again, not having pillows under the knees. Okay? Big pillows under the head because they promote contractures. If there's a lot of back discomfort, sometimes just elevating the legs maybe 8 inches can help if they're laying in bed. Getting people to lie in the prone position once a day so they keep the flexibility in their back can be helpful. And a firm bed. How about heat or cold? Do we have as much inflammation here? No. So usually heat's going to feel a little bit better. Okay? And deal with that. Because the cold decreases the inflammation. Use the cold on acutely inflamed joints. This is where you're going to see ultrasound and whirlpool. And some of those paraffin baths can be helpful also. As far as pain is concerned, sometimes when the pain is severe, we try the NSAIDs, some of the corticosteroids to decrease some of the inflammation, but it's not really that much of an inflammation. The COX-2 inhibitors. A TENS unit can be helpful to interrupt. Have you seen a TENS used? What's a TENS? Electrical stimulation to break the pain cycle, okay? And they can be useful for what you're doing. And again, one of the things, too, is never massage an acutely inflamed joint, okay? And teaching a patient not to rub, because what do you do if something's inflamed and hurting? You want to rub it, okay? So don't rub an acutely inflamed joint. As far as meds are concerned, where did that one go? Okay. Meds, a lot of times we have aspirins and NSAIDs. We said corticosteroids can be used. What about glucosamine and chondroitin? You hear a lot about that. The glucosamine, what they're finding, the glucosamine, the thought is it decreases the wear and tear on the body. The thought that is it would help repair some of the cartilage, the glucosamine part of it. The chondroitin may inhibit enzymes that break down cartilage. Okay. So far, what have the studies showed, though? There's no real studies out there showing that it's helpful. Okay? But you do get these wonderful anecdotal stories, So most of the physicians I know will be like, try it, and if it works, great. Okay? With the problem is it is not regulated by the FDA, so what's the issue? Okay, what are you getting in the medication? Is it the actual dose that they're saying and things like that? Okay, so that becomes the big issue for what you're looking at with that. The other thing that they're starting to see with some of these meds is we've always seen joint injections, right? They'll inject a joint with a steroid, right? Decreases the inflammation, can be very helpful. Okay, what do you have to be careful about with joint injections with steroids? Infection with the joint. Breaks down bone. Okay, so it can break down bones. You have to be careful how many you're getting and the long-term effects. The other thing is the viscose supplements. Have you heard people getting injections of the fluid into their joints? It's like a synthetic fluid that they're putting in to help lubricate those joints so they can move. Some people have great success with them, and some people just don't seem. Anybody know anybody who's had those? No. Success? Yeah. Success? Okay. So some people do and some people don't. There is more research looking at platelet-rich plasma injections, looking at that in hopefully decreasing the joint damage that's going through. There's also some research being done and some work being done with actually taking what's the damage here? Cartilage, right? They'll take out somebody's pieces of cartilage and grow it in a test tube and then replace it. The swimmer had that done up in Boston. She was the older swimmer, Olympics. I can't remember her name. I can't remember her name, but she was one of the people that had that done. And there's some research, varying results. It hasn't really taken off with what they're looking at. There is a new DMARD, a disease-modifying med that they're looking at. Hasn't been approved in the United States that I know of so far. It's being used a lot in Britain. Okay, and it's called strontium ranelate. Strontium ranelate. And what they're finding is that they give this, and the strontium gets into the bone, and it strengthens the bone. Okay, so it increases bone formation, and it prevents deterioration in the microarchitecture of that bone. So it's really being looked at the fact of using it with osteoarthritis, because a lot of the drugs we're using are what? Preventing the breakdown, but not helping the buildup. Okay? So this is one of the new meds that are looking at that's helping with the buildup of the bone.
Would that be similar to like Forteo or something like that?
Yeah, similar to like that. Yeah, Forteo a little bit, and that's one of the newer ones out there too, to help build up that bone. But this one looking a lot at, again, building up the bone and the bone formation. So again, it's being used a little bit especially in postmenopausal women. And it's finding to decrease that risk of the development of the osteoarthritis. So you may hear more about that. Treatment, again, bracing, range of motion. I've known some people who have, they have a lot of problems with their hip and their knee. What happens? They may have an unloading brace that they use that takes some of the weight off their joints. They can use some of those. Using good range of motion. Preserving that function, physical therapy, having pain control. Some of that surgical intervention. This is a little out of order. Osteotomy, again, surgical treatment. They may resect some of that bone fragment just to correct an deformity. They may remove the articular surface so it will heal like a fracture. Or what's the big one? Joint replacements. Okay, we go in. Now, hips. You've had the whole joint replacements part, right, in freshman year? Because you see so many of them. When do they like to do the joint replacements? If you're having trouble at 50, do they do the joint replacement? Okay. They don't like